Thank you for joining us today. My name is Dr. Jokho Farah. I am a physician by training. I work at People-Centered Clinics and Services over by Cedar Riverside, and I lead their population health and quality improvement work. So really working alongside the providers to develop culturally relevant care for our patients, for our diverse patient population, and making sure that we're centering their voices as we deliver care to them. So thank you for joining us, and we are excited to have you and to present to you and share some resources. And so I'll just take it away. So in order to just keep us grounded and orient us to this presentation, our objectives for this presentation is to sort of kind of review the impact of policy changes on safety net providers and underserved populations in Minnesota and their effect on access, quality, and reimbursement, define strategies and resources to help adapt to the challenges of operating within our changing environment. And then Roli.
And we will be analyzing the role of the safety net providers and community organizations, how they play a role in promoting the health equity. And then we will be talking, me and Jokho have done a lot of interventions together, not only locally at our clinical level, but at the system-wide interventions, which we would like to share today.
Thank you. So just to give you some kind of background information about our clinics, so that you get to know us and the work that we do. People Center is located in South Minneapolis, particularly in the Cedar Riverside neighborhood. Our mission is to deliver affordable health care, inspire hope, promote community wellness. And then our vision is to improve lives, transform communities, achieve health equity for everyone. Now, in particular, the Cedar Riverside has always been known as the point of access or entry port for immigrants, stemming from the 1800s when the first wave of immigrants came to Minnesota in particular, and they were predominantly Scandinavian. And as they got established, they moved out and into other parts of the cities, Twin City metros, and we saw the second wave of immigrants around the 1900s. Usually, they were new immigrants fleeing from countries of persecution, so like the Irish, and then the Korean, and then the Vietnamese, Ethiopian, and finally now we have predominantly a large Somali population. Now, Cedar Riverside in particular is considered one of the densest zip codes between Chicago and West Coast. So we have 10,000 people living in about 1,300 unit housing. So you can think about the number of people living in just one unit. Of those, about 40% of those patients come from 67 different countries and speak over 90 languages. So the point to understand here is that English is probably not their primary language. 65% of those are people of color. Of that, majority of them are African-American, particularly new immigrants. So think about African-American and then also new immigrants, the challenges with new immigrants coming into the country. And then when we look at high school attainment, 22% of them have only achieved high school level education. And then majority of them used public transportation as their means of how to get around in the Twin Cities. And almost above 95% of those individuals are renters, so they don't own their homes. So you can imagine the income that goes towards their housing.
So a little bit about CUHCC. So as I said, Community University Healthcare Center, and there's a little bit of difference between People Center and CUHCC is because we are federally qualified healthcare center, but we are also a university clinic. So we are University of Minnesota clinic, and there are only last time I looked, I think there are only 8 federally qualified healthcare center nationwide, which are part of the university. And I also wanted to mention for both me and Dr. Farah is that we have a patient governing board and the community governing board. So they set the priorities and because they are speaking from the community perspective. So this mission and vision that I have displayed here, it is a combination of CUHC employees and the board together. So advancing health equity and transforming care and education is our mission. And we are also a residency site or the education site. So we get about 160 to 200 students or residents who come to our site every year. So we are trying to work hard in developing knowledge, skills, and attitude on our current force and also future force so that they can fit the need of our culturally diverse patient population. So we are leading in education, and which leads in the team-based care and centers towards not only on the person, but the family and the community experiences. We also are almost similar to People Center in terms of the patient population. Our 80% of our population is BIPOC population, and about 41% of them don't speak English. 12 they come from the 12 different racial and ethnic communities. And in terms of the race, about 38% of our patient population is Black race, and then about 26% are Hispanic and Latino, and then the rest is just a combination. And sometimes we just say, like, we have a global health in our backyard because we basically serve everyone. CUHCC has been serving the patient, our patient and the community for more than 50 years. And depending upon how patient come to that neighborhood, based on their lived experiences, based on their immigration journey or the refugee journey, they come and situate there. So our patient population has been changing every couple of years. So when we actually just a pediatric clinic, and then families started saying, well, we have adults too. So then the adults started coming to us, and then we have a very, very robust mental health services. Go ahead, Farah.
Yeah. So as my partner, Dr. Roli, was mentioning, both CUHCC Clinic, their model of care is essentially a one-stop shop where we try to provide behavioral health, medical, dental enabling services. When we talk about community health centers, we've always been rooted in the social justice movement. They were birthed out of the civil rights movement in a way to combat the war on poverty. And the intent was to make sure that we empower our community, that they are neighborhood health centers. But in addition to that, making sure that we were providing a point of access or entry to care that was relevant to them, that was culturally relevant to them, that met their needs. And so, as Roli mentioned, that our community health centers in particular are 51% of our board has to be patient, comprised of patients, so that we're constantly making sure that we're staying connected to the needs and the voices of our community. And so when we think about all of who we are and what we do in the population we serve, you've heard from both of us that majority of our patients are patients that are disenfranchised, patients that are vulnerable, patients that are underserved, uninsured, that don't speak the language. And so when you use that context and you think about COVID, as we know already in terms of in just regular daily living outside of COVID, we've experienced BIPOC individuals in particular have experienced health inequities that have led to health disparities.
So we also wanted to share a little bit of data, and maybe some of you have already looked at this data because it's all over, how COVID has disproportionately affected the people of color or the BIPOC population. And this slide is very well displaying, and it's very recent slide. And you can see that how disproportionately it has affected our Black populations and Hispanic Latino population and Asian population. So even though the intention can be, let's develop the system, but the impact is not right. It is still disproportionately impacting the BIPOC population. So what else can need to be done? How can we define the system? How can we change the system? How can we address the structural racism? How can we address the institutional racism? How can we address the personal racism? Those are the deep-rooted things which are going to improve, hopefully, this graph in future. So how can we be ready for the next pandemic?
Mhm. So when we think about this, as Roli, Dr. Roli had mentioned, you know, the age-adjusted rates allows us to compare groups of people based on age and how the disease affects them. And when you think about the numbers and our population, when you look at the Native American population in particular, the American Indian or indigenous community, the total population is about 60,000. So when you have 7,000 of those patients being or having testing positive for COVID, that's a significant amount. And part of it is understanding sort of the political determinants of how the structural inequities that exist that are perpetuating these kind of rates. So this is a continuation of hospitalizations, again, disproportionately affecting our communities, and particularly our Native American Indigenous community, our Blacks, our Latinx, and our Asian community, as compared to our white counterparts. This is, we also notice that the vaccination rates are equally, follow the same pattern when it comes to the COVID testing and the vaccination rates. We start to see that, again, our BIPOC communities that we serve are still trailing and many of it is, we'll get into it, is addressing some of the distrust with healthcare systems, access, understanding the benefits, relevant information, and timeliness of that information.
And if I can add to Dr. Farah's comment about, so initially when COVID hit us, when the Minnesota all over was at the 4% positivity rate, when we looked at our internal data, both People Center and CUHCC, our positivity rate was 16% to 24%. So that tells the story, like where our populations are and how it is disproportionately affecting the BIPOC populations.
So when we talk about impact in our community, so early on, we talked about who we serve, right? We talked about their race and ethnicity. We talked about their primary language. We talked about their education and employment level. We talked about the means and ways in which they move. So public transportation. So you can think about COVID as it relates to public transportation, the school attainment. Many of these individuals are at high risk for these conditions, and many of them already have underlying conditions that further impact their ability to really fight off this infection if they got it. And so when we think about our communities, you know, majority of them are essential workers. They didn't have the privilege nor the opportunity to be able to work from home, right? Meaning that day in and day out, they had to go out. When you take into account information and awareness is not being disseminated effectively in a language that they can understand, that puts that person into a disadvantage. Secondly, knowing that the majority of our individuals are not homeowners, right? They're renters, and having to keep up with sort of the financial burden of daily living. Many of them, again, if you remember about the 10,000 individuals in 1,300 units, majority of them live in multi-generational homes. So the idea of social distancing and so forth becomes relatively difficult in small quarters. And so I just
if
wanted
I can
to
comment on if I can comment on one word. So as this has been the theme of this conference, that picture says 1,000 words. This picture is like how our community went from these smiling faces on the right side to the other side where people are lining up for the food. So the other side of the picture is actually the weekend after the unfortunate Mr. Floyd, when the Lake Street was destroyed and our communities were hurting and we were in the pharmacy desert and the food desert. So CUHCC Clinic just stood up the food drive, and everyone, including the staff and the community member, they just brought food, and it was so well appreciated by the patient, because a lot of, as Dr. Farah said, and as we have a common patient population, a lot of our patients have the lived experiences of being in war, being in the refugee camps. So food is the first thing that people are thinking that we are in the war, and we are in the war. So that was very well appreciated, but it also, they are already suffering from the trauma, and it has COVID did another trauma, and then murder of Mr. Floyd did another trauma to the communities. And that, how it impacted is that it caused more fear. People coming to the clinic for the testing or to seek access to the care. And that's where our collaboration started.
Mhm.
We wanted to talk a little bit about the impact of the policy, and especially with the COVID. And you already heard about our patient population. And I know that, like, as soon as the COVID happened, a lot of bigger healthcare system were able to build the MyChart visit or the telehealth right away. But we were not able to do it right away because our structures were not supported, while the other healthcare system were supported, but the digital disparities are real. And our patients, a lot of our patients do not have a smartphone, or they do not have the internet access, or they are experiencing homelessness. And the only thing that they can do is to walk into the visit. Or they might have just only mobile phone with not video options. So it was a big, really big barrier for us to just launch the telehealth right away. And there was a lot of a struggle happening in terms of policy that phone visits should be reimbursed at the same rate as the video visit. And it is still a struggle, and we are pushing, because a lot of our patients just wants to do a phone visit rather than the video visit. But at the same note, everything cannot be addressed by the phone visit. So how can we dig deeper, and how can we provide or change the things at the policy level where they can have access to the video visit? So, I mean, how do we prioritize the developing payment model that focus on delivering the system with an outsized role in caring for uninsured and publicly insured patients? And then, as I said, much of the existing digital infrastructure does not include non-English speaking patients. So how can we create the system and the policies or the portals where this can be addressed? How can we invest in the technologies create the policies where the chronic disease management can happen on a daily basis? Or how can we advance the technology forward in the health system in an equitable manner, where we can provide the capacity building program that specifically target the workforce? Because even within an organization, there is such a difference between the skills, how to use the technology, prioritizing the broadband access to the low-income people. So these are some of the examples that that we need to keep working towards and keep pushing forward as the healthcare delivery system is changing, because we know that the mobile care is not going to go, or the technology or the telehealth is not going to go, but right now system are not matching. So how can we build the technology system which are a good fit for the federally qualified healthcare center or the community center, so that we can provide equitable access? Because if a person is going in a suburb, a person is going into the healthcare system, they can easily access, and then the people who are seeking the care at the community care should have the same type of access.
So when we think about, the strategies and resources, we talked about our patient population and some of the challenges and the barriers that exist for them. When the state rolled out their COVID response, the COVID is something that is a novel thing. It's new. We've never seen it before. We don't know how to, there wasn't an emergency preparedness plan that we could follow that would guide us in how to really address this and roll this out in an equitable manner. And so when the state rolled out their COVID response, it was quickly inevitable some of the gaps that existed. The information that was being delivered to the community, many of whom we serve, did not speak English. And so information was not getting to them in a timely manner. We realized that there was limited testing. The testing initially was being delivered at hospital systems, and you had to be a patient of theirs. And therefore they didn't, people who wanted these essential workers that wanted to get tested if they felt like they were having symptoms and things like that were being turned away because they were not patients. Talking about the relevancy of facts, another thing that we need to address is the fact that many of the populations that we serve have experienced a lot of trauma at the hands of healthcare systems, there have been medical abuses that have taken place, and therefore trusting a healthcare system about testing in particular, when we have historical context where mistreatment has taken place, trying to educate people and trying to get them to understand that this is something that they need to be aware of, and that giving them the relevant facts that they need in order to protect themselves, to seek help and access if they need it, were some of the things that we knew that we could leverage our relationship with our community members and develop ways in which we could give them relevant information, find ways to stand up mobile testing, request additional funding to help meet those that were still hesitant, right? And so we had to consistently stay on top of current recommendations. We had to partner with MDH to make sure that the information that they were sharing out to the community, we would in turn quickly turn around and translate that information and get it out to our community so that they were receiving the information at the same rate as English-speaking folks. Secondly, we had to make sure that we were also addressing the mistrust. And provider relationships came into play a huge role in ensuring that our patients got tested and that they got their needs addressed. Leveraging the beauty about being community health centers is that we have a collective learning collaborative known as FUN, Federally Qualified Urban Health Network, which is comprised of 10 community health centers, and where we share information, we share how to disseminate things, leverage our resources so that we're able to scale our work, but also to reach more people. And then in terms of access, as I mentioned, initially when they rolled it out to hospital systems. And in order for us to be able to because the community trusted us, in order to be able to stand up our own testing sites within our own healthcare system, we had to request funds in order to be able to build the infrastructure and then be able to deliver the service in a community informed manner and an approach. Every step of the way, we made sure that we were checking in with the community to make sure that this is what they wanted and that it was reflective of their needs. And then making sure that we shared any information that got, any successes we got, any lessons learned that we got, so that we helped someone avoid sort of the pitfalls and the redundancies and having to recreate the wheel in terms of trying to stand up not only a health center testing site, but also a mobile testing site.
We have already talked a lot about the importance of community health center, but again, just to name some, that we provide holistic care, and then we are the first entry to care. We provide holistic care and the whole person care. So then people, once in the building, then you can get physical, mental, dental, spiritual, everything in one building. And then we were also, we're the first one actually to stand up the drive-up testing as well. That is the beauty of important the community health center. And this is our work that we have done together, the People Center and the CUHCC. So with all this going on, me and Dr. Farah started working together, like, okay, communities do not have access to the testing. Communities do not have access to the care. There's a lot of fear going on, and there are a lot of social determinants of health. So what can we do? So we went back. I'm not originally from this country. So we went back to our global health model where a provider goes underneath a mango tree and provides the care to the community. So that's what we did. We will bring care to the communities because the communities are at this point are not ready. So we just launched our mobile testing units together. We started developing the protocols and the procedures and the flow and collaborations and the relationships with the different communities, and that helped in launching that.
In addition to that, besides our collaboration as community health centers, we wanted to make sure while we were meeting the needs of patients where they were at, that they were informed by the community. And so therefore we had to identify key stakeholders, key community partners that would help us also help us make decisions around logistical, the logistics about standing up a mobile testing site, about the timings, right? Especially given the fact that, that we had a large Muslim patient population, understanding prayer times, when would be a good time to do these mobile testing, understanding that many of these individuals, not that we're under COVID, had children, and how to do it in such a way that people could come out and get tested, and still be able to carry out their daily lives, so to speak. And so we worked with, Volunteers of America. We worked with the city of Minneapolis to kind of help us with coordination. We worked with Minnesota Public Housing Authority that helped help us identify residents that were interested in getting tested, so that we knew when we were going into certain sites that we had the patient population, that we were ready, that we organized, and we were planned for who we were about to test. In addition to that, we had to also continue to advocate at the state level for additional funds so that we could scale this work and go into other parts of the community to be able to provide this testing. One thing to note is that, and if some of you attended Khadijah's presentation yesterday, she mentioned that she partnered with CUHCC at Fells Park to provide testing for individuals that were lived and were serving community service individuals that were keeping sort of the George Floyd Square together.
So after this intervention, I think it was noted that the community collaboration, trust in the community leaders, and is the only way to go. As it was mentioned in, I think it was yesterday's talk, that in order to create a fabric, you need a collaboration, and you need to pick who's going to bring the silk and who's going to bring the thread and who's going to choose the color, and then you create a fabric. So we started, so it was noted, my work and Dr. Farah's work was noted, and I was called upon to build a task force, which was based on Dr. Tolar from the University of Minnesota and Governor Walz. When Governor Walz realized that there are so many disparities, I was asked to create a task force, and that is, when I did the task force, the first main thing was that we wanted the people who are supposed to be in the task force. We wanted the people to be on the table who were actually going to make the difference. So our task force has a representation from the community leaders representing multiple cultures and ethnicity. And that helps us because I can create a task force, but it's not going to do anything unless I have a relationship with the folks who are going to make a difference. And this, so you can just see, this is a bubble diagram, but how this has a collaboration, and these are small bubbles and the connectors, and how these are like, it's just basically a web. It's creating a web and how you make a difference. And that has, we have worked together, and not only improving the access to the testing, but also a huge work towards the vaccination events as well.
And as you can see, it started off with the two bubbles, the community clinics and people set out at the very right corner, and it's developed into this massive, as Dr. Roli mentioned, a web of interconnectedness, and knowing that this work requires all of us to take part of it, and that it's a collective effort in order to be able to combat this. And the same strategies that we use for COVID testing is what we use for our vaccination. The beauty of it was we didn't really have to reinvent the wheel. We just used the existing infrastructure that we created for COVID testing, and use that same those same strategies and redeploy them to do the vaccination. As Minnesota Community Health Centers, we were about 17 collective clinics in the state of Minnesota, and as of this month, we have vaccinated about 100,000 individuals, which is a lot if you think about it. And it's making sure that folks that are often been marginalized and disenfranchised are getting equitable treatment. And so this is just data to show we did about 400, I think 450 to 500 testing at mobile testing. This is just mobile testing. And I believe Cook Clinic did about the same amount, but and so forth.
And we have to say, like, this is old data. So this was the beginning. This was the seed before, when the testing was not there. So after that, a lot of testing started happening, but this was the beginning of the seed of the mobile testing.
Okay. And then in terms of total testing, People Center has tested about 9,727 individuals, and we've vaccinated about 5,300 individuals. And you can see sort of the first dose and second dose kind of numbers.
Cook data has changed a little bit. It's about like more than 4,000 now. This is a little bit of older slide, but so we have like almost done 4,000 vaccination so far.
Yeah. So we are at the end of our presentation. We're wondering if there are any questions. Feel free to kind of put them in the chat if they've come into the chat.
And while people are thinking about the questions, I wanted to say few more things, because we both believe a lot in the community building, and Cook hosted an event recently, where we invited imams from all over the Minnesota, because there was a lack of confidence in two particular communities. One was the Somali East African Muslim communities, and then one is the Hispanic Latino communities. So we said, it's not a vaccine hesitancy. They want the vaccine. There's a lack of confidence what we can do, or it is an access. So when we invited the 16 imams, they came to Cook, they got their vaccines, and they were from all over Minnesota, including rural. That was channeled into Universal TV, Somali BBC, and then other areas. And that had a huge impact. Soon after that, communities started asking us, can you come and do the vaccination? Because there are so many structural barriers. We have to fill a 3-page form. This is online. Filling the form is just so, I cannot read English. What do I do? I don't know where to click, how to click. Can you do the vaccination? So we just recently went to a mosque or a masjid where we did about 170 patients, the community members, in 2 days. We went to CAPI, which is the immigration center focused more towards the Mongolian or Southeast Asian communities, and we did 93 vaccination in 1 day. So that is unique because sometimes there are unidentified barriers, and we have a lot of assumption without knowing, because if we would not have done that event, I would not have known what were the barriers at the community level.
Right. And similarly, People Center has done about 450 vaccinations in the community, particularly around Bryan Coyle and other places in South Minneapolis. And part of it is people are interested. People don't have the information to make an informed decision to get vaccinated. And part of it is understanding how do we give that information in a way that they'll be able to receive it, that is factual and that's effective, so that they can make a decision about their own health and their community, right? Because again, it's multi-generational kind of unit. It's a community unit. So we have about 3 minutes to answer some questions.
I want to be sure, I want you to answer the questions, but I also just want to say thank you so much for sharing this work with us. This was so impressive. And I love the idea that you were able to go to where the people were and just find ways that to reduce the barriers. It's such important work. Thank you.
Thank you.
There was a question about, are you seeing some hesitancy in people coming for the second vaccine? Not as much, but yes, some. And we have done a lot of like, especially through the task force, we have done a lot of educational events. So for example, we have gone to Mujeres Latina Facebook Live event twice. And the questions were different. We gone to the Wilder Foundation webinar. We did a public facing webinar, which is on our website. We created a frequently asked question for all sort of questions, which is housed on our website. We went to Hispanic, Latino, Spanish TV. So I think just making sure that you are out there and answering questions, and every culture in the community has a different type of question. For example, I can give one of my patient, husband and wife are trying to conceive, and they are struggling with the secondary infertility. And somewhere in the social media, they heard about that if you get the vaccine, then it will cause you the infertility. So these are the kind of the questions. So we have to take the question from the individual experiences and what is out there in the social media. Also in the task force, we created, okay, this community takes the information by utilizing WhatsApp. So how can we do the WhatsApp messaging? This committee, this particular population is using nomadic hustle. So how can we do that? This particular generation watches this TV. So I think just going out into different venues and creating the educational event has been successful.
Yeah. And just using things that that already exist to make sure that we're using resources and sources that people already use, and leveraging that to deliver our message and addressing the needs that way, instead of having to think of something new entirely.